So very good evening to all of you. Today, our guest speaker for the day is Dr. Spero Catalan from Ohio, USA. And he's going to lecture us on atypical hemolytic uremic syndrome. This webinar is brought to you by Mumbai Hematology Group, supported by Netco Oncology, and managed by Perfect Square. I thank Mr. James Rajkumar and Team Netco, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Spero Catalan from the Ohio, USA, all our discussants who are themselves eminent hematologists, and you participants for spending your Saturday evening. Tomorrow, that is 27th of August, 2023 Sunday, we have a webinar on approach to bleeding disorders from 11:30 a.m. IST onwards by our own speaker, Professor Dr. Maitri Bhattacharya from Kolkata. Let me introduce our discussions for the day and here displayed in alphabetical order. To start with, we have Dr. Ashish Dixit from Manipal Hospital, Bengaluru, Dr. Ganesh Jeswantwar from Yashoda Hospital, Hyderabad, Dr. A.R. Jaswanthini from Yashoda Super Specialty Hospitals, Hyderabad, Dr. Kripa Bajaj from Basavatarakam Indo-American Cancer Hospital and Research Institute, Hyderabad, Dr. Mallikarjun Kalashetty from Manipal Hospital, Bengaluru, Dr. Pujitha Baireddy from Care Hospitals, Banjara Hills, Hyderabad, Dr. Radhika Keke from Nizam's Institute of Medical Sciences, Hyderabad, Dr. Satish Kumar from Manipal Hospital, Yashwantpur, Bengaluru, Dr. Sindhura Lakshmi from Kasturba Medical College and Hospital, Manipal Academy of Higher Education, Manipal, Dr. Steli Bala Chaudhary from Nizam's Institute of Medical Sciences, Hyderabad. Now it's a time to introduce our guest speaker for the day, Dr. Spero Catalan from Ohio, USA. Dr. Spero Catalan is Professor of Internal Medicine in the Division of Hematology at the Wexner Medical Center at the Ohio State University. He is also the Director of the Benign Hematology Program at Ohio State University. He received his medical degree from Ohio State University College of Medicine and completed his residency at Ohio State University Hospital, after which he went on to complete fellowship training in hematology oncology at the University of Chicago Medical Center. After completing his training in hematology, he returned to Ohio State University, where he presently remains on the faculty. His clinical and research interests include TTP and atypical HUS with an emphasis on immune-mediated TTP. He directs the Biomarker Reference Lab at Ohio State University, which performs correlative laboratory studies for ongoing research. He has a long-standing interest in the development of long-term complications in patients with a prior history of TTP and the mechanisms for their development. He has also worked to establish the United States Thrombotic Microangiopathy Clinical Consortium, an organization of over 15 academic medical centers that was organized to conduct collaborative research in TTP and atypical HUS. Today, he is going to lecture us on atypical hemolytic uremic syndrome. Well, thank you so much. Over to you, sir, for your lecture.
Thank you very much. Let me see if I share screen again to get the slides back. I think everybody can see my slides, or at least I hope so.
Absolutely perfect.
Good. Very clear. Well, it's really an honor to be asked to come back and speak again to you. I enjoyed my time the first time around, I think 6 months ago, and it's a pleasure to come back again to discuss really an extension of what I talked about last time, which was one specific thrombotic microangiopathy. Here, we're going to talk about thrombotic microangiopathies in general, but then start to venture away from TTP into things like atypical HUS, which we're now going to start calling the more appropriate term as a complement-mediated TMA. But also we'll talk a little bit at the end about maybe a novel form or etiology of a TMA to help understand it. So our understanding of this used to be 20 years ago, these were called TTP/AHUS because they were similar appearing clinically. The treatment was the same, and they were sort of viewed incorrectly at the time to be the same thing. So now, really, as our knowledge of these disorders has grown, our categorization, I think, has grown and improved as well. And we now understand that the TMA is not a diagnosis, but it's a finding. It's used pathologically to reflect microthrombi in an organ, typically the kidney, but also clinically to reflect thrombocytopenia and fragmented cells. And when we talk about it in that way, there's multiple etiologies. HUS or atypical HUS, so the sugar toxin associated form is the HUS, and the complement mediated or atypical HUS. There's TTP, but there has to be a recognition that many more common medical conditions will give you the same clinical findings. In my hospital, thrombocytopenia, fragmented cells in the peripheral blood, and an absent haptoglobin, and the jump is to AHUS or TTP. But I back them up and say, what about things like DIC? In somebody who's got malignant long-term hypertension, you need to think about that. Pregnancy has its own form of TMAs. In addition to the postpartum presentation of HUS, there's things like preeclampsia and HELP that are in this spectrum. Autoimmune disease, vasculitis, and particularly lupus and scleroderma with scleroderma kidney that we'll talk about today. But metastatic cancer-associated TMAs, drug-induced TMAs that included gemcitabine, mitomycin, as well as other medications that have been shown to give the same clinical picture. So when people jump right to TTP, I try to pull them back a little bit and say, let's step back and think about all potential etiologies. So obviously, the most important thing that most physicians think they need to do, and I think correctly, is to make sure this is not an ADAM-TS13 deficient driven TMA or TTP, because that's going to be treated a bit differently. It's more of a medical emergency. But one of the first things I do, and we'll talk about the plasmic score next, but really the plasmic score is based on the principle that multiple investigators, including our group many years ago, have shown that patients who have a severely deficient ADAM-TS13 activity-driven TMA. So these are all in all of these studies looking at patients who had a TMA and those that were eventually found to have severely deficient ADAM-TS13 activity. And the pattern's pretty clear. You've got a lower platelet count than what you saw in the patients with a non-deficient ADAM-TS13 TMA. So a lower platelet count and renal injury, but not renal failure. And again, in the patients who had the non-deficient, they're normal ADAM-TS13 driven. So their TMA is not driven by severely deficient ADAM-TS activity, greater degrees of renal injury and renal failure, and a higher platelet count. That really is the basis for the plasmic score. It's a nice numerical score, and physicians, especially in the US, like numerical systems as opposed to subjective judgment. But if you really look at the plasmic score, the criteria we use to diagnose TTP are thrombocytopenia, typically lower, as we just talked about, fragmented cells, and really no other explanation. And that's really what you get with the plasmic score. When you're looking for a score of 6 or 7 being highly likely that you have severely deficient ADAM-TS13 activity present. And remember, again, this plasmic score predicts the ADAM-TS13 activity. TTP remains a clinical diagnosis. But when you're in a score of 5, 6, or 7, these are the patients you should be more seriously considering plasma exchange therapy until you get the ADAM-TS13 activity back. But you can look very quickly if you've got a platelet count less than 30 that we talked about, renal injury but not failure, evidence of hemolysis, and no other explanation, cancer, stem cell transplant, and some other variables that were found to be predictive. You can see right away you're at 1, 2, 3, 4, 5. It's not too hard with that thrombocytopenia and lack of renal failure that is unexplained to get to a clinical diagnosis of TTP and a greater likelihood of having severely deficient ADAM-TS13 activity. But we're going to go past that today and talk about complement activation in hematologic disease. And we'll start with what I think is an interesting case. So here's a 20-year-old female transferred from an outside hospital with acute renal failure, thrombocytopenia, and fragmented cells or schistocytes 7 days postpartum. And they're concerned for a diagnosis of TTP. So when I get this message, a few things pop into my head right away. Renal failure requiring hemodialysis, which she did eventually. But when I hear renal failure, and I hear 7 days postpartum, this really clues me into the high likelihood of this being a complement-mediated TMA or atypical HUS. TTP does not give you renal failure, and in general, TTP is going to show up in the second or third trimester. Postpartum is fairly unique and consistent with a complement-mediated TMA. So she actually had a cesarean section for an uncomplicated delivery. She was mildly thrombocytopenic at discharge. But after she went home, she had 7 days of progressive lower extremity edema and increasing shortness of breath. And when she arrived at our institution, she was started on hemodialysis for renal failure. So again, this is starting to fit right off the bat, something more of a complement-mediated TMA more than another form of TMA. Her laboratory studies that we've got are consistent with this as well. She was already anemic, being pregnant, but now you've got a platelet count of 36,000, really distinct and different from what you might see in TTP. And you've got a great degree of renal injury with a creatinine of 6.7. The ATOM TS13 activity was not available, but you can predict, and you'd be correct, that she had normal or measurable ATOM TS13 activity. So fragmented cells, renal failure, evidence of this microangiopathic process that you see in this slide, and her postpartum presentation, and you're thinking very quickly about atypical HUS. So let's step back just a second and get a hematologist perspective on the complement system, which is obviously a very complex disorder that I had to relearn 10 years ago as I got back into this area from medical school, as I'd long since forgotten it. But the complement system is part of the innate and adaptive immune response. It's important for things like the opsonization and lysing of bacteria, so helping to help the host fight off infections. It's also very important for the local inflammatory response. And some of the mediators from the complement system help to influence the adaptive immune system, promoting inflammation via the breakdown products, the C5a, the C3b, a role in debris or dead tissue clearance as well. So there's three different arms of it: the classical, the alternative, and the lectin pathway that really all converge on the formation of the terminal complement pathway, this formation of the membrane attack complex. But simply stated, very simply stated, this classical pathway is triggered by antibody-antigen interactions. And it's primarily from the C1q, the complement factor C1q, binding to the FC portion of antibodies. So leading to the initiation of classical pathway of complement, the formation of this C3 convertase, which produces C3b, which is going to be important for the optimization of bacteria and their clearance, but also some of this also leading on to forming the C5 convertase, important in the membrane attack complex that you see here. So this is really the damage arm of the complement system. It's a very powerful system. The alternative pathway does not require antibody interactions for its activation. It's thought to be auto-activated, or meaning this tick-over effect. It's always level and active at a very low level, kind of monitoring and probing the environment, producing C3b. These sort of biologic factors then can end up on cell surfaces, but in normal tissues, the activation of the complement is rapidly terminated on healthy cells or in the fluid phase. It's amplified on foreign or damaged cells to then form this C3 convertase, as we already talked about, a slightly different one, but then also forming this C5 convertase that leads again to the formation of the membrane attack complex and doing the damage that this complement system can do. So very complementary systems working together to help protect the host. But when they go awry, there can be significant consequences, as in the case I just showed you with renal failure. This is my late research collaborator, Haifeng Wu's simplified version that a hematologist or a blood banker might understand. But similarly, you see the alternative pathway, the classical lectin pathways converging on the formation of the membrane attack complex. But I want to emphasize here that eculizumab or ravulizumab, the complement blockade agents that bind C5 and prevent the formation of this membrane attack complex, occurs right here. So you can't form this membrane attack complex. It's important to emphasize that blockade of complement does not heal the patient, the host. It just blocks further injury from occurring. So when someone has an ongoing TMA from dysregulated and overactive complement activity, this blocks the complement activity and stops it. And that's why recovery from an acute complement-mediated TMA episode is a function of how much injury is present before therapy was started and the duration that it was present. So long-standing chronic injury is not going to get better, but the body has an impressive capacity to heal. And if you can start this in a relatively short period of time, you can block further injury and healing will certainly follow. To put this disorder in the context, this is work from now 12, 13 years ago from Marina Norris. And if you exclude this MCP or CD46 variant that has a mild course thought to be self-limited, gets better with supportive care, recurrent episodes of TMA, but again, they get better with supportive care. If you exclude that, what you'll see is all other genetic variants, roughly half of patients at the first year are either dead or permanently on kidney dialysis. So this is a serious disorder, and unfortunately, I took care of many patients where they failed plasma exchange therapy, the only option at the time, and we saw poor outcomes clinically. But you can see multiple different genetic variants that either impair some normal proteins that control the immune system or the complement system, factor H or factor I, or you can get gain of function variants in, say, C3 or factor B, where the normal control proteins then are thought to be less effective. But very much like TTP and ADAM-TS13 deficiency not alone enough to create a TMA episode, this second hit hypothesis is present. So this is someone who's born with typically a genetic variant, but then either in childhood in a more significantly affected patient, or getting into adulthood and getting pregnant, having surgery, infection, or medications can activate complement and serve as the second hit to lead to clinical disease in somebody who may harbor a pathogenic complement genetic variant. So the efficacy of eculizumab was really shown in one study by Legendre et al. It was a very interesting study. It had two arms of this study. One was patients who were clinically diagnosed with atypical HUS and a progressing TMA. So after 4 plasma exchange or infusion procedures, the hemolysis and the renal injury was not improving. But equally interesting was trial 2, which was run at the same time. These were patients who had a diagnosis of atypical HUS, but they had a chronic form of the disease with chronic renal injury, and they were on prolonged plasma exchange or infusion. So these are patients who responded to therapy, but just could not get off of it. The dosing went for 26 weeks after a lead-in time period of observation. But the dosing is what you all would recognize as the typical dosing for eculizumab, 900 milligrams intravenously weekly, and then starting at week 5, 1,200 milligrams every other week. There was additional doses given for plasma exchange or plasma infusion, but also, as you all already know, the complement system is important for fighting meningococcal disease. So meningococcal vaccination is initiated in all patients, as well as prophylaxis for at least the first 2 weeks prior to the vaccine becoming effective. So that was the study design. If you look at the patients, you can see the median time. This is what I mentioned to you, that especially with trial 2, the chronic patients, the time from the diagnosis to screening on the study. In trial 1, there's 9.7 months, which is quite a long time. In trial 2, it's even longer. It's 48 months. Dialysis required before the first dose of eculizumab. A third of patients in trial 1 were on hemodialysis, with a smaller number, because these, again, were the ones that were responding to therapy. But if we look at the platelet count on presentation, as we talked about earlier, they have a mild thrombocytopenia. This group, the median was normal, which reflects the hemolysis being improved by the plasma therapy. But also looking at the serum creatinine micromoles per liter, both with clearly injured and damaged kidneys in both arms of the study. So if you look at the response, and graphically, you can see this well in trial 1, and I'll show you trial 2 in a second, but this emphasizes an important point, is that when you start somebody on complement blockade therapy, the first thing you should see in the first week quite rapidly is an improvement of the hemolysis. So the hemolysis, the microvascular injury, is a function of complement activation and injury. So when you block complement activation, as you do with eculizumab, the hematologic or hemolysis recovery should happen first. And that's actually what you saw very quickly, the increase in the platelet count in the first week of therapy. But then if you look over time, what happens over the 26-week treatment period and the extension period, you see a more significant improvement starting gradually as you move through the time period of the 26-week treatment. So the longer they're on treatment, the longer injury is blocked, there's time for healing. But if you even look at the extension time period, there's even improvement that's seen long after that first 26 weeks. And I don't think today we exactly know when recovery is completely capped or not going to get better any further. So once you block that injury, recovery then will follow and may take significant period of time to peak the recovery. What I think is even more interesting is this trial 2 patients. So these are the ones, and this is the pre-treatment period here, you can see, and the 26-week treatment period and the extension treatment follow-up. So these were the ones that were thought to be responding. So even though they were thought to be responding based on the hemolysis getting better, once they had a more effective therapy, once the process of complement activation that was causing the injury was blocked, you saw a greater improvement in the GFR over time that continued into the extension period. So when people ask me, is it too late to start complement blockade therapy? The honest answer is the sooner the better, but you don't know. And many times we'll give people a therapeutic trial to give them a chance to recover. You all already know about ravulizumab, the long-acting C5 inhibitor that received regulatory approval for PNH and now atypical HUS. It's got increased elimination half-life, so patients can be dosed every 8 weeks. A phase 3 study showed it to be, and there's a follow-up coming very soon that's going to show the efficacy still remains, even in long-term follow-up, similar to eculizumab. So a more favorable dosing schedule and equal efficacy. So you see that the majority of patients will go on to this long-acting form rather than the eculizumab. But I think we'd step back for a second and talk about the diagnosis of atypical HUS and confirming the diagnosis. It's a very difficult diagnosis because in most cases, or many cases, I should say, you don't have that confirmatory test, these genetic mutations. But it's important to emphasize, and I think this is a problem maybe from some of the early work done by the company that produced the medication. They sort of had the message indirectly that normal atom TS13 activity in the context of his TMA is AHUS. And although that's going to be a population enriched for that disorder, there are other potential explanations. So just because you have normal or measurable atom TS13 does not mean you have AHUS. You need to exclude other potential etiologies. Hypertension, as I'll show you in a case coming up, is an important feature, but it's kind of tricky because patients with AHUS have a very difficult to treat hypertension. Even when they've responded to therapy, kidneys have improved, they usually remain on multiple antihypertensive medications. But it's very common. Most patients will have hemolysis. At least 2/3 will have evidence of hemolysis on initial presentation. You may see a family history, but there's a very low penetrance of these genetic variants. So patients may have obviously a familial or congenital inheritance of these mutations, but most families, nearly all families, won't have any history of unexplained renal failure or a diagnosis of atypical HUS. The mutation studies are very helpful, but 60% of patients will have one, 40% do not. You also want to try to use response to eculizumab. So when you start, and we just started a patient here in the hospital 2 days ago, when you see the improvement in the platelet count, a decrease in the LDH, the hemolysis markers, in the first several days, it gives you some comfort that the diagnosis is likely correct. In our case, the patient's platelet count hasn't responded in 3 days, which makes me wonder if this injury is driven by complement, overactive complement activation. So when they don't respond to eculizumab, it could be just the findings are chronic, the renal injury is just chronic and irreversible. It's also possible that you don't have the correct diagnosis, which is certainly a possibility. So when patients don't have the true hemolytic picture, when they don't have a documented genetic variant, as roughly 2/3 will, and especially if they don't respond to a trial of eculizumab, you're going to be more likely to exclude that diagnosis and look for another cause of the TMA findings. But again, as we already talked about, you're going to see the hematologic response first, followed then weeks or months or even a year later, the renal injury recovery. So this is an interesting case of a 29-year-old female with no significant medical history, had her first pregnancy without difficulties without event. But her second pregnancy was complicated by placental abruption, DIC, and then renal failure requiring hemodialysis. Then she also had a hemolytic picture, the elevated LDH, thrombocytopenia, and as you can see, the serum creatinine of 6.9 milligrams per deciliter. So it's certainly clinically a TMA that's present. It's happening postpartum. It's a bit strange that she didn't have a problem the first time, but also her second pregnancy was much more pronounced, which was much more of a clinical event. And it may be she's somebody not too predisposed to complement dysregulation, but a very strong clinical event could push her over the threshold. And I think that's what happened to her. But she was given complement blockade therapy, as we had no other explanation for her clinical presentation. Her genetic studies came back, and I'll show you here at the top. These are from the University of Iowa. The typical genetic variants that are studied are factor H, I, MCP, or CD46. You can get a gain of function mutation of complement factor B or C3. Those complement factor H related proteins are studied. DJKE is a disease that tends to present very early in childhood. It does not respond to complement blockade therapy. Rare to get to adulthood and be diagnosed with that. But also the plasminogen gene, which is involved in the clotting system, as we'll talk about a little bit later. As well, the ADAM TS13 is studied as well. But in this patient, she had a complement factor I genetic variant documented, but by modeling, it was predicted to be likely benign. And these reports from the University of Iowa and other centers will tell you and report based on criteria that this is pathogenic, benign, or of unknown significance. So clinically, I think this fits. She has a genetic variant that is likely benign. She didn't present earlier in life, and she didn't present at the time of her first pregnancy. So it's somebody you might consider stopping complement blockade therapy on. We can talk about that more later. So this one's not so easy. This is a 31-year-old male, history of a neuroblast stone as a child, and he was really well until about 5 years ago. He presented to an outside hospital with fatigue, shortness of breath, calf tightness. He was diagnosed with Raynaud's disease and treated for a vasculitis. And you can see his labs. He has a platelet count that's decreased, but not very low, and serum creatinine and a BUN that are both elevated. So again, fragmented cells, clinically a TMA with end organ injury present. He had a kidney biopsy that showed acute TMA findings. So again, it's important to emphasize I'm not a nephrologist, but I've learned from the nephrologist all of those different TMA etiologies that we talked about can all look the same on a kidney biopsy. The biopsy itself tells you a TMA is present, does not tell you the etiology. It's also interesting they had acrocyanosis, which is not something you typically see in a complement-mediated TMA. He was transferred to Ohio State. He was already started on eculizumab, and he was slowly improving, and over the next several months became independent of hemodialysis. He had genetic studies done. And again, if we go back, he had the thrombocytopenia, he had the hemolysis, but there were other potential explanations as well. His genetic studies, though, did not show a causative variant. So he might be in the 40% that have HUS that don't have a genetic marker, or this may not be complement driven. So eventually he became independent of hemodialysis, which is encouraging. It makes you think this might be a complement-mediated disorder. But you've got this history of the acrocyanosis that didn't fit. The other possibility is, did he just get better despite the eculizumab? And scleroderma kidney, for example, as we'll talk about in more detail here in just a little bit, there's no known treatment for it. It just gets better with supportive care, not necessarily with eculizumab. He eventually underwent kidney transplantation. He's doing well, but then was diagnosed with scleroderma. And he's got very significant systemic scleroderma right now. So what does he really have? Could he be one of the 40 patients with AHUS and no identifiable genetic variant? Or maybe more likely, was this scleroderma initially without other manifestations of scleroderma? So the question is how long to treat him with complement blockade therapy, and he's anxious about this idea, but likely going to stop it very soon. As all of the evidence now, in retrospective, certainly suggests that this is probably not a complement-mediated TMA. So we'll talk about a case with hypertension. This is a 29-year-old white male with only a history of a diagnosis of hypertension, diagnosed at age 15. And it's important to put his race in here as a white male or a Caucasian, as they are not thought to be able to go on to kidney failure from just hypertension alone. He had routine blood work 1 year ago. So he was diagnosed many years ago with hypertension, never followed up, never took medications, had some blood work drawn, and was found to be in acute renal failure despite having relatively few symptoms. His kidney biopsy showed chronic renal injury, lacking the acute changes. He had an obliterative microvascular injury, intimal thickening in the arterioles, and few fragmented red cells. At this time, he had no evidence for thrombocytopenia or hemolysis, just the renal failure. And looking back, no clear evidence of having any evidence of a hemolytic picture. So we are at the question of the chicken or the egg. What caused his TMA? Was this uncontrolled hypertension that led to chronic injury and the TMA in the kidneys? Or was this a complement-mediated TMA, which can have a significant component of hypertension? And again, the idea that hypertension causing renal failure is less of an issue or less common in non-Blacks in the US. So it's hard to know. We had no evidence of hemolysis. He was never symptomatic, and they were never documented. He eventually was studied and found to not have a genetic variant. So I think putting all of this together, we have an idea of a possible etiology, even though it's less likely in whites. He does have uncontrolled hypertension, and no question it wasn't being managed. He's now genetically negative. He has no evidence of hemolysis. This suggests that this is likely not a complement-mediated TMA, which is very important for him for donor selection. In a patient who has a complement-mediated TMA or atypical HUS, family members are not routinely selected for donation because of the potential that they could develop an acute TMA at the time of surgery to harvest the kidney, as these are inherited genetic variants, especially problematic in patients who don't have an identified genetic variant, as you can't even screen family members. In his case, because of his picture and the other findings in the genetics, we say this is likely hypertension, therefore opening up his family members for donor selection. But that's an important point in managing these patients. We're not going to talk a lot about it, but a big question in the States and really around the world is complement blockade and length of therapy. And what you can see from some of the work from Fadi Fakori from France, a pediatric nephrologist, looking at the patients with a relapse of AHUS during follow-up. And you can, as you can see here, the patients that had a genetic variant, a pathogenic variant identified, were the ones who developed relapse during follow-up. If you didn't have a genetic variant, your risk for relapse in this series was low than zero, suggesting that in those patients, if you don't have an identifiable genetic variant, you may be able to safely stop complement blockade therapy. And in some follow-up work from Dr. Robert Brodsky, the now president of ASH, you can see that they have sort of a schema that he and Shrita Chaturvedi have put together with treatment with complement blockade therapy. It's an old figure, so ravulizumab could be added here as well. If they get a complete clinical response, looking for germline genetic variants, and if they do have one, understanding that the risk of relapse is probably 50%, can vary based upon the specific complement genetic variant, factor rates likely being the highest rate of relapse. But you could consider stopping complement therapy, with factors also being used at the ability to tolerate a second hit, and also the age of presentation. In a younger patient who may present, they get out of childhood but present in their 20s and 30s, we think of them as being closer to the threshold where milder clinical events may trigger an acute TMA. So in patients who present earlier in life, and patients who won't tolerate a second hit to recover again, you would not want to stop complement blockade therapy. But again, if they are able to tolerate a second hit, interested in stopping it, it's certainly worth considering. But in contrast, those without a documented genetic variant, the risk of relapse is felt to be low. It's safer to discontinue complement blockade therapy, assuming they would tolerate a second hit were it to occur. Someone who might not tolerate a second hit in terms of losing completely and permanently their kidney function, you might not attempt stopping therapy. So as I said at the beginning, we're going to emphasize it now. This is more than just TTP and atypical HUS. And there's a lot of things that we appear to know, but as we'll see here in this upcoming series of cases, I think there's a lot of things that we don't know. And I think you learn something over the years practicing medicine, especially academic medicine. And I'm starting to really believe that good clinical care leads to good clinical research. And what we see clinically causes us to generate hypotheses and ask questions. And if we look back at a lot of these clinical classifications that we use in some disorders, there are some classifications that just don't work so well. They're the best that we've got. And I would tell you the thrombotic microangiopathy is at the top of the list. And best example is when I started practicing medicine in 2000 here at Ohio State University. This AHS was a pediatric disease and adults do not get it. That certainly changed with our understanding of atypical HUS, and especially the responses we've seen from eculizumab therapy, starting with the studies around 2010. But in the same category where the clinical classifications aren't too clean and differentiated, myeloproliferative neoplasms and bleeding disorders. And I think we have to be careful when there's an atypical test result that don't fit clinically with the proposed diagnosis. You've got to step back and think about other possibilities, including things that may not yet be defined. So as I like to tell our trainees, you got to use a little extra thought on these cases before you just dispense the idea. And this is work done by Shreya Agarwal, a pediatric hematology fellow here at Children's Hospital in Columbus, doing a 1-year hemostasis and thrombosis fellowship. But she started working on this project that has now been submitted to ASH that she'll present here at ASH this December, hopefully as an oral presentation. But this is a patient that I saw initially about 2 years ago, 49-year-old female who came from Oklahoma to see me. So we're talking about a 15-hour drive to get to see me. She was very motivated to be seen by me because of having a lot of experience in seeing these TMA disorders. And if you look at her history, she had multiple recurrent TMA episodes in 2005, 2007, 2011, 15. As you'll see in the next slide, she inserts a stroke here in 2019, sort of unique for a young female. 2020 and 2021, she had acute TMA episodes. And as we'll talk about more in the next slide, these last two episodes occurred while she was taking eculizumab and then ravulizumab. So there's a couple things clinically that just don't make sense. And the first one of those is looking at her initial presentation labs. Although she had renal failure requiring dialysis, her platelet count was 10,000 at presentation, which really isn't consistent. It could certainly happen, but it doesn't make any sense. She did have renal failure, which is atypical for that degree of thrombocytopenia, but again, it would still be possible. But what was interesting is on plasma exchange therapy, all of these times renal failure recovered. Her kidneys improved. That's not very common. Only a third of the time will kidney injury get better with plasma exchange therapy. And based upon this, the team at Oklahoma City was convinced, and I would agree, that this was TTP. But unfortunately, she had normal ADAM TS13 activity. So you can't call this an ADAM TS13 driven TMA. If you look at her clinical course, for when she's diagnosed in 2005, she's two thrombocytopenic normal, coupled with acute renal failure. Again, presumed TTP, plasma exchange, hemodialysis, and again, presumed TTP and hemodialysis don't go together in the same sentence typically. And as we found out later when the testing was available, she had normal ADAM TS13 activity. And again, after multiple episodes, not knowing what to do, the physicians then diagnosed her as a diagnosis of exclusion with AHUS, started on eculizumab, but still suffered a cerebrovascular event and then recurrent TMA episodes. I've seen probably 130 to 140 patients with atypical HUS, and I'll tell you that relapsing on treatment is a unique and rare event. It's happened once in my career, and it was a patient who was running out of drug from recurrent infections. So it's not something you see. So there's a lot of red flags here, starting with relapsed episodes on complement blockade therapy, which tells us her TMAs are not driven by dysregulated complement activity. What's also unique about her is if she had a congenital complement dysregulation disorder, she presented later in life, which certainly can happen. I'm an adult hematologist. I don't see kids. What was also unique is she had 2 previous pregnancies. So if she harbored a complement genetic variant, it would be kind of strange for her to get through 2 pregnancies and not have a problem. So putting that together with this failure of complement blockade therapy raises the question of what she really had. If we look then to her genetic studies that she had, she was actually found to have a genetic variant pathogenic of the plasminogen gene, as is routinely done in patients with AHUS. So it makes you ask the question, should we be doing something different? What should we do with her? Because complement blockade therapy certainly isn't helping her. Does she need to be on something like prophylactic anticoagulation therapy for this microvascular disease? Let's go back to the complement cascade. And it's dangerous to show the complement and the coagulation cascade in the same talk. But as you can see, plasminogen is converted to plasmin, which is involved in lysing these fibrin-linked clots, these cross-linked fibrin clots. So this is involved in fibrinolysis. So it's certainly plausible, and you see this from the initial reports that looped in plasminogen with an atypical HS or TMA clinical picture, that abnormalities in fibrinolysis could lead to increased thrombosis and this same clinical picture. It also might explain why she would not respond to complement blockade therapy if it was being driven by a coagulation disorder. So if we step back and look at plasminogen deficiency, it is described, it's an autosomal recessive disorder from biallelic mutations. So she was heterozygous. This is rare. Only 12,000 cases reported worldwide. 1 in 400 people can be carriers. But what it's characterized by are these fibrin-rich pseudomembranes on mucosal surfaces that can injure organs and lead to obstruction. Could be vision loss, pulmonary symptoms, urogenital symptoms, or CNS symptoms from having these plaques. When they get placed on plasma therapy, plasma infusion, giving them plasminogen back, these lesions regress. But what's interesting is they are not documented to have venous thromboembolic disease. They just don't get clotting issues, which is a bit different. So 2 years later, this is a good exercise in humility. I was asked by a colleague at the Cleveland Clinic to see this patient with a TMA that didn't make any sense. And my colleague said to me, he said, she's having recurrent episodes. She's coagulopathic. It looks like DIC, but she's got normal ATOM TS13 activity. And she was seen by a very good hematologist, a rheumatologist, an immunologist. I looked at the labs and said, I'm not sure if there's much I can do to help. But this rheumatologist, I think this is another lesson in persistence. The rheumatologist was persistent. And at the same time, the hematologist reached out to me. The rheumatologist did as well. And she said, you've got to see her. You've got to give it a shot. And I said, I'm not optimistic I can help, but I'm certainly willing to give it a try. You don't know what you don't know. So she comes out to see me, and her history is quite interesting that she's had 3 recurrent TMA episodes in the past 5 years. 2 happened when she was traveling. In 2 of these 3 episodes, she ended up on hemodialysis, but with varying different treatments, very similar to my previous lady 2 years earlier. And this is when things start to trigger for me that maybe there's something different going on here. But it's strange that to get on hemodialysis and to get off it without competent blockade therapy was a bit strange. She recovered after each episode. Her records indicated that she had a CD46 or MCP genetic variant that we talked about earlier. And these are variants, and I've seen a couple of these cases. They tend to get mild, self-limited TMA episodes. So the creatinine may go to 2 or 3 milligrams per deciliter. They're thrombocytopenic, but no matter what you do, they tend to get better. They don't routinely go on competent blockade therapy. They just get watched, again, treated with supportive care. But I didn't find a copy of the report. The severity of her episodes, although it could have fit with CD46 mediated TMA, didn't quite fit. They tend not to do that. So I thought, let's repeat her genetic study. She came all the way to Cleveland to see me. That's the least I can do. And her genetic renal panel, the typical one, was negative, as reported by Dr. Smith. But they did now, and this is a more recent patient, report her as having a plasminogen genetic variant of unknown significance and listed as a contributing risk variant because they did not believe it was a driver of her disease. However, they could not exclude it. So then things start to register and make a bit more sense. We're seeing a pattern between the previous lady from 2 years ago and this lady now. We were starting to discuss putting her on prophylactic anticoagulation therapy when she called me. I was out of town giving a talk. I get a phone call from her and she said, I'm driving home from a trip again. I'm getting bruises. I feel badly. I've got abdominal pain, nausea, and vomiting. She said to me, this is the same as the previous episodes. And they're starting to get closer together. So she wanted to drive home and get labs tomorrow. She's a brave woman. I said, why don't you go to the closest large hospital in Cleveland, which was the Cleveland Clinic. When she shows up at the Cleveland Clinic, her initial labs show her to be not anemic yet, mildly thrombocytopenic. But very quickly, I got a phone call from the hematologist, and we had a good discussion, a very good hematologist, about these treatment options. And of course, the first option, when they're seeing the patient, they want to go plasma exchange for TTP. And I let them know, this lady's been checked multiple times. Her TMA is not driven by an ATOM TS13 deficiency. I'm not telling you not to do plasma exchange, but I don't think this is TTP. We talked about her history of having a plasminogen genetic variant, but take a look at some of her initial clinical presentation, her data. So within a day of her getting to the hospital, she went from a normal to a creatinine of 4.5. The LDH was markedly elevated at 3,400. She has undetectable haptoglobin, certainly evidence for hemolysis. This is clearly a TMA episode. What was frightening is that her high sensitivity troponin was markedly elevated. She was not coagulopathic, but had a very high D-dimer, which remember is going to measure degraded fibrin cross-linked, so split products. And what was very interesting is hematologists, they had in-house a plasminogen function lab and were able to document decreased plasminogen function. So the discussions then went after a day or two, what should we do? This looks like DIC, but it's not DIC. Plasma exchange, there's no inhibitor to remove. No history of this being driven by ADAM-TS13 deficiency. And the hematologist very accurately and astutely said, why don't we give her plasma to restore her plasminogen function? Maybe that makes a difference. And that's indeed exactly what happened to her. She responded to the plasma infusion, normalized, and then after discharge is one of the patients that we've since placed on long-term anticoagulation therapy with Eliquis. But now going back, and as I said, good clinical care or clinical experience really feeds into good clinical research. So after seeing this last patient and working with Shreya Agarwal, who needed a project and wanted to work on a project in TMAs, I said, I think I've got just the project for you. And she went through our cohort of about 125 patients with atypical HUS, all of which that have been characterized by genetic studies. And looking back, we actually found 5 patients with plasminogen gene variants. And we started to see some recurring themes. First of all, they were all females. They'd all had multiple deliveries. So I think there was 7 or 8 total childbirths in this population and not a one with a postpartum TMA presentation. You see some variability in the platelet count, but in general, almost a near normal platelet count. There's renal injury and failure on presentation, with 3 of the 5 needing dialysis right away. But at the point of last follow-up, only 1 having persistent renal failure requiring dialysis. What's also interesting is, do we have patients who had eculizumab failures? And we do. There's no question that we do. This is our patient here from the first one from Oklahoma that I described, and this is the second one. So it's very interesting. In the patients, we have 3 of these patients with eculizumab, none of which that responded, 1 with failures, and the other 2 with renal injury that did not recover, which is remarkable given the relatively timely starting of therapy. So a failure and poor response to complement blockade therapy certainly got my attention. But also looking back at this patient here at the bottom, this lady was treated somewhere else, labeled as a lupus anticoagulant induced TMA, and at the time placed on warfarin. I'd been seeing her for about 5 or 6 years, but never got triggered until we did this bit of an analysis here. And she was on warfarin for a completely different reason, but that may be what is protecting her. So she has done well. Her lupus anticoagulant has faded and is no longer present. So this may give us a more plausible explanation for what happened to her. So these are data you're going to hear more about, I hope, at ASH coming up here as it's going to be presented. And it may be a novel format of a TMA. And a real quick story at the end, Nishant Tiwari is a medical resident from India who I'm working with now, who gently and persistently approached me 2 years ago about wanting to get involved in a research project. And he actually sent me this article about a year ago when it was published, but it didn't register. But as I was writing his letter of recommendation for a hematology position that he's applying for right now, I went through his CV and found this report and was relatively shocked to see this is exactly what we saw in our patients. So maybe this is divine intervention that this was pushed back into my face again. And exactly what Nishant saw in his patient that they thought looked like TTP, but was a plasminogen genetic variant, is starting to make some sense. And it appears that this patient is very similar in that a lack of response to complement blockade therapy as well. So again, hopefully more to come at ASH this year. So I thank you all for your attention. Here's a picture of one of my happy places in the world in the southwestern United States, in the mountains, and of course, a golf course stuck in between. So thank you very much for your attention and the invitation, and happy to answer any questions that you have.
Thank you, Dr. Spero Catalan, for that wonderful lecture. Fantastic to hear to you. What a beautiful lecture. It was awesome
Thank you.
about this plasminogen gene variant. It was an eye-opener for all of us. Thank you so much
It
for
was
being.
an eye-opener for me. It took me 2 years to have my eyes open, though, which is typical for me.
Thank you so much, sir, for being with us. And I now request all our discussants to please put the raise hand signs so that we can start our question answer session with Dr. Spero Catalan. So, in the meanwhile, I have a question for you, sir.
Sure.
So, can HUS can present you with a normal platelet count?
It's a good question. It can. I mean, a third of patients will have no evidence of hemolysis. And the explanation I've been given by smarter people than I, nephrologists, is that this is a cellular disease with cellular injury. So what we measure in the plasma and the hemolysis is really the secondary event. So I've been taught, and I think it's true, you can have um, a complement-mediated TMA and a normal platelet count, but it's the minority. It's a third of patients. And I think you need to use that with the genetic studies if you have them available, as well as the response to complement blockade therapy.
Thank you, sir. Another question is that if the patient has got peripheral smear with full of cystocytes, LDH is around 200, retic count is 1%, creatinine is 5, on hemodialysis, there is no other evidence of adenine activity is absolutely normal, adenine level is normal, and there are full of cystocytes in the peripheral smear. Bone marrow is also normal with some erythroid hyperplasia. What would you label this entity as?
That's a tough one. I mean, I think a lot of times the best diagnostic test we have for these complement-mediated TMAs is the lack of another explanation. It's someone who has long-standing hypertension or being a poorly controlled diabetic. When you have another explanation, I think it's reasonable to say this is not complement mediated. Had several pregnancies, didn't develop any problems. But in the 35-year-old, without another explanation, as long as there's access to drug, I think they deserve a trial of complement blockade therapy. And I think it fits with using the hemolysis, the genetic variant, and the response to complement therapy to help really confirm collectively your clinical diagnosis. It's hard. That's the tough ones.
Yes, thank you so much. Dr. Jaswanthini, your question, please.
Yeah. Sir, thank you for that enlightening talk. Actually, I just have a doubt. Is there any role of plasminogen activity inhibitors, PI1 gene and HUS, sir?
Yeah, there's been some discussion about the role of the plasminogen activator inhibitor. I don't think much is known about it. In theory, it's the activation inhibitor should help block this activity. It's hard to know the interaction of these proteins. I think we're still early on. I mean, it's not really known to be a thrombotic risk factor in terms of venous thrombosis, but neither is plasminogen variant as well.
Actually, we have a case, sir. Actually, young female, 28 years, primary. Post delivery, she developed renal failure. She was on hemodialysis. When she came to us, she presented with typical TMA picture. Cystocytes were high, LDH was high, RMTS 13 level was normal. So we thought of atypical HUS, but we didn't have the declusma facility in our hospital. So she was given plasma exchange. She recovered. And post discharge, again 2 weeks, she came. There was suturing of the wound. So she presented with excessive bleeding from the suture site. So TEG was showing hyperfibrinolysis disorder. So PI1 gene and alpha-2 antiplasmin levels were sent. Mutation study was sent. And she came up with PI report as 4G, 5G phenotype. And she developed acute DVT. 2 days back, she came to our OPD with acute DVT presentation. And her PI report was 4G, 5G phenotype. So we were confused whether this has anything to do with atypical HUS or both are like different presentations.
It's hard to. You said she developed a venous thrombosis also.
Yeah, sir. External iliac vein, like spreading into superficial and common femoral, popliteal, everything.
And no other explanation for it. Now, did she get better when she got the plasma exchange? Did her kidney function
Yeah, she got
improve
better, sir.
in a couple of
Yeah,
days?
she got better actually. She was in hemodialysis,
Yes.
but once the plasminogen is done, kidney function improved. Creatinine was normalized. There was LDH improved, platelets count improved, and that's why we discharged her actually.
You know, it's certainly possible. It's certainly possible because the kidney function doesn't improve that even in complement-mediated disease, when you treat them, it takes them usually weeks or months to respond. And our patient who got the plasma infusion at the Cleveland Clinic, within 4 or 5 days had normalized her platelet count and normalized her serum creatinine. And actually, one of the local hematologists wanted to put her on plasma infusion, but that's so cumbersome, we elected to go with prophylactic anticoagulation instead.
Yeah, we have started
But I think
that.
that's certainly suggestive that there's a dysregulation in PAI1. Yeah.
Thank you.
I think there's a lot we don't know about as you get past HUS and TTP.
True, sir. Thank you, sir.
You're welcome. After I give a talk about TMAs, I like to tell people if after we're done, if I've made this very clear, then I've done something very wrong because it's not very clear.
So you're absolutely perfect. Thank you, Dr. Jaswantini. Dr. Ashish, your question, please.
Thank you very much. It's a complicated topic, and just making us understand part of it was really something to learn. My question was more related to the duration of the therapy that you're going to choose. So two questions mainly. One is in case there is a pathogenic variant of this complement gene which you identify, what's the advice for the female patients who are planning pregnancy or willing to get pregnant? Would you like to give them? Because then you're planning a long-term therapy with a complement inhibitor. And second is in those who are not having the genetic variants, the duration of complement inhibition that you're planning to do usually after an acute episode is over.
It's a good question. So I think the pregnancy is the first question is a good one. And there is experience in PNH patients with eculizumab, and eculizumab is now thought to be safe in pregnancy. But before we knew that for sure, we would still place people on eculizumab therapy because the argument always was, although safety is not assured for mom and baby, there's no question if somebody has a pathologic genetic variant in the complement system and they get pregnant, they're at great risk of developing a postpartum TMA and doing damage to the kidneys. So our approach has always been, if they're on ravulizumab, to switch them to eculizumab. And if they had come off therapy, we'll put them back on either mid-pregnancy or at the beginning of pregnancy after discussing with them. But I think that sort of folds into, you've got there obviously patients with a genetic variant and they have a second hit that's clear and present. Really no different than a patient with an estrogen-mediated venous thrombosis who then becomes pregnant. But I think the question of who you stop with is a great question. The patients with a clearly pathogenic genetic variant, those that present at a very young age, and those that have a severe first event and might not tolerate a second one are the ones that we won't stop it on. But it's also interesting, patients going up to like 2016, even 2017 and 18, the mindset was different. It was among physicians that you may never be able to stop this. So people diagnosed at that time are of the mindset that we're just never going to stop it. And they don't really, I talk about it at every visit, tell them it's an option without a genetic variant. They don't want to talk about it. Patients diagnosed in the last 5 years, it's a reasonable thing to think about. So I think it's kind of how it was presented to them. But I think in a patient without a documented genetic variant, it's reasonable to stop it in a patient that you trust, that you know will call you if they have symptoms.
Thank you very much.
Sorry, that was a bit longer than you wanted. I apologize.
Thank you, Dr. Ashish. Dr. Satish Kumar Enumala, your question, please.
Yeah, thank you, Amit. Thank you, Dr. Spiro, for that enlightening talk.
Sure.
So I had a couple of questions. Have you seen any patients of acute pancreatitis presenting with TMA? So I just wanted to present this case. I had a 27-year-old unmarried female who was given azathioprine for some arterial vasculitis. She developed pancreatitis. She sort of developed when she came into our hospital. She had some sort of DIC, PT, APT was prolonged, platelet count was low. and there was histiocytes. There was definitely evidence of MAHA on the smear. So we sent Adam-13. Luckily for us, within 24 hours, the Adam-13 level comes and it came normal as expected. And we started Plex and even steroids. Gradually, the platelet count improved, and then she recovered. We sent for a genetic panel by NGS, and again we're lucky we get the report within 3-4 weeks, and it came negative for any genes.
Negative.
And slowly with the Plex and steroids, she recovered. We don't know what helped, if at all those helped or not, but she recovered. And when I looked into literature, there are cases of TMA reported with acute pancreatitis. This is the second case I'm seeing self-limiting TMA with pancreatitis. I wanted to know your opinion, sir.
Yeah, that's an excellent question. I've done this for a long time, like 22-3 years, and I think I know what I'm doing. But I'll tell you, these acute pancreatitis, and there's reports of acute pancreatitis mimicking TTP and being Adam TSH2 normal, but they will fool you. I had a patient actually from the Titan, or it was the Titan study, the caplacizumab study. We almost enrolled a patient with a pancreatitis-induced TMA. Same exact picture. Platelet count was 10,000. Kidney function was not that bad. LDH was 1,500. And right before we enrolled her, we got our Adam TS back and it was normal. So you're exactly right. The pancreatitis-induced TMA, and that's the correct term, is a great mimicker of an Adam TS deficient TMA for whatever reason. You're exactly right.
And they're usually self-resolving. I think once the pancreas subsides,
Yes.
it's resolved.
Yeah,
Thank you so
exactly.
much. Great
Another
question, if Amit allows, is 40% of the patients you said will not have any identifiable genetic mutation or something like that. So in those cases, how do we diagnose? It's only therapeutic response to eculizumab. If they respond, we take
It's
it as
hard.
request.
Yeah, we get the studies back about a month and a half later. So it's after the initial treatment. And the genetics don't predict response to AHUS. So we would typically, if we have access to drug for the patient, and if we have no other explanation, we want to give them a try. We know the sooner you treat, the better the chance for recovery. So I think by the time we get the genetics back, it may be 2 or 3 months. And then we can use, was hemolysis present initially? Is there a genetic variant? And did they respond in the appropriate way to complement therapy, meaning hemolysis better first, and then over time the kidneys get better. Then we'll use that all collectively as a diagnosis.
Right. Once the patients go into dialysis and we start the therapy late, what are the chances of recovery of kidney function?
It's still very good, actually. I think in the second step, remember, it was about 2/3 of patients who are on hemodialysis will get off. And I tease my nephrologist here that I fix more kidneys than they have with this initial diagnosis of AHUS. So they will still have a chance to get better. If you look at, that study, median of 9 months on that study. So we still give them a try, unless they've got a kidney biopsy that shows a scarred kidney. We'll give them a short course of therapy, at least 3 months to try.
Thank you so much.
Sure. Excellent question.
Thank you, Dr. Satish Kumar. From the same token, I had a similar case of pancreatitis-induced TTP. And we have managed in a very similar patient by just plasmapheresis. The ADAMTS13 level was low, but it was at the level of 28.
Yeah.
Well managed with plasmapheresis. Now the thing is, basically for this, there are so many articles which are focused on pancreatitis-associated TMAs, and they've used steroids plus plasma exchange. Is it okay that we use steroids in this case of pancreatitis-associated TMA, sir?
I think it makes sense to use steroids when you think it's an antibody-mediated process, and usually it's a couple of days till you get the Adam TS13 back. I mean, at that time, I would probably stop them because I don't think they're doing anything. And it's funny, it's hard. TTP is a clinical diagnosis with the Adam TS testing as an adjunct. So I always tell patients, I'll tell the other physicians especially, that there's no antibody here. There's no severely deficient protease. There's nothing to do with plasma exchange. We'll stop it. And I'll probably also stop the steroid. As I get older, I'm more respectful of steroids and the damage they can do. So I try to stop them as quick as I can.
And there was also, sir, ASH publication of the other way around, that TTP causing pancreatitis. That was also a publication.
Yeah.
How would you differentiate between pancreatitis causing TTP or TTP causing pancreatitis?
I guess I would say that TTP, the microphthalmic, can affect any organ system. We don't typically see it in the pancreas, but maybe in the patient with pre-existing pancreatic injury or insufficiency, with that, they get it. So I think that's the humility of medicine. Anything is possible. We look at patterns and we try to understand. but we can't be too arrogant and say because of this, it's not, we understand a lot about the human body. We don't understand everything, I don't think. And that's where we get these nice surprises where we learn things once in a while.
Yes, sir. Thank you so much, sir. Dr. Radhika, your question, please.
Thank you, sir. Thank you for presenting a great topic in a beautiful manner. My question is on, in all the cases presented by you in your presentation, we have only been talking about eculizumab, the use of eculizumab. Eculizumab is not easily available in our country, or if there is a patient who is non-responsive to eculizumab, do we have any other alternative manuals for these patients? Can we explore steroids or bortezomib or any other alternative regimens?
Yeah, I mean, plasma exchange, it works a third of the time. 2/3 of the time, the hemolysis gets better, but that's not the issue. The issue is really the kidney injury, and only a third of the time will plasma exchange work. It's not clear why it works. So maybe some of them are things like this Plasminogen variant, which get better with just plasma infusion. So plasma exchange works a third of the time. We've done that in many patients. It's not really clear why, other than removing abnormal complement proteins and adding back functional ones, it doesn't make sense why you would have a long-term response, but you do in a third of patients. I think there are a lot of patients, if we look at it, an acute TMA episode, I think can be a result of any clinical event in a patient. And the ones who have a genetic variant, or the ones that have a more pathogenic variant like a factor H or factor I, are just more predisposed to it. So I equate it to like an unprovoked venous thrombosis where something triggered them, but it's very minor. It's not clinically apparent. So they're just closer to the threshold with the variants. But I think we all have the potential to develop a TMA episode. We just have different amounts of stress we need to get there. And it's these patients with AHUS and the variants that are more likely to do it and have recurrent episodes over time. So the short answer is, other than plasma, we're not sure of anything else that really works other than complement blockade therapy.
My second question is...
Good question, though.
I have a second question, sir.
Sure.
Whether a germline variant is present or it's absent, the management strategies are the same. So the treatment doesn't vary depending on the germline variant.
Correct. What really changes is the risk of recurrence in the future. So having one or not having one. And maybe, again, that's that same question we just talked about before. With the variant, they're closer to the threshold of their impaired management of their complement system puts them at greater risk. And the one without a genetic variant is less likely to relapse. Maybe it was a more overt. I mean, that lady I presented in her second pregnancy, they got a TMA. Her first pregnancy was fine. Second pregnancy, she had abruption, DIC, that caused her to go into renal failure. And it fit that her genetic variant was one that was thought to be benign. So really not thought to be a factor. So maybe it's just she's somebody who needed a more severe episode to go on to that acute TMA.
If a female has a germline mutation positivity, do you recommend us to go for prenatal screening for the next subsequent pregnancy?
It's a good question. We know that these are obviously inherited, but because the inherited the penetrance is so low at 30%, we don't routinely test people. It's hard to do it outside of a clinical trial. Many patients ask. We've got a couple families that clearly have a history of renal failure running through generations, and there's no question that we know where it came from. But we don't routinely test for fear of making somebody anxious without necessarily doing anything about it. And in the US, making an insurance company anxious will result in higher rates or no insurance for you. So it's hard to routinely test.
Thank you, sir. That was helpful.
Thank you.
Thank you, Dr. Radhika. There are some questions which are coming from the audience. One audience wants to know that what are your comments regarding lupus manifesting as TTP and how do you manage these cases?
Oh God, that's a hard one. You earn your money with those. With the cytopenias and the thrombocytopenia and lupus and the predisposition to renal injury, that's a tough one. You may end up doing empiric plasma exchange therapy until you get your ATOM TS13 testing back. But there are many patients that we will say, this does not look like TTP, but I can't not do plasma exchange. I need to start it until I get the ATOM TS13 back. And I think lupus patients, that's a good example.
Thank you so much, sir. Anybody has any other question for Dr. Sparrow? So any discussants want to ask any question, because I finished all the questions from the chat box and there are no more questions in the chat box. Yeah. Dr. Pujita Bairedi wants to know, what is the role of rituximab? Do we add frontline for every patient of TTP? As well as
I think, yeah.
TTP?
Yeah, I think in TTP, yes, it is frontline. It's being used up front. It's used to preemptively prevent relapse. But I didn't talk about it, but there are autoantibodies that lead to atypical HUS more in kids than adults, but autoantibodies against factor H and factor B are well documented. So patients with those will get they'll get complement blockade therapy with immune suppressive therapy, and rituximab is part of that, is my understanding. So in those rare cases where you're creating autoantibodies against factor H or B, yes, it does have a role.
Thank you, sir. Any discussion want to ask any other question to Dr. Sparrow? Well, so there are no other questions in the chat box. And yeah, that's all. Fine. So, sir, thank you so much for being with us.
Thank you.
Morning for you and evening for us on this Saturday.
Well, thank you for spending your evening with me. I appreciate that.
Thank you so much, sir. And it was a wonderful lecture, an eye-opener lecture for all of us, and a wonderful discussion. Thank you for being there. Wonderful discussion, wonderful question answer session, and very, very fantastic lecture, sir.
Oh, thank you. Thank you for the excellent questions. You guys are always great with the questions. So I appreciate that. I learned.
Thank you. Thank you.
Take care, everybody. Bye.